Welcome, and thank you so much for joining us at the Iowa Ideas Conference. This is the Maternal Health Disparities session. This session is part of the Diversity, Equity, and Inclusion track. I would also like to extend our thanks to our DEI track sponsor, Inclusive ICR. We will now play our sponsor video.
Hi friends, Angelica Veneta, co-chair of Inclusive ICR. We are a coalition of over 220 employers in Eastern Iowa, all working together to grow the diversity and inclusion of our workforce, to create a space where employees feel a sense of belonging, included, and valued. Inclusive ICR is a proud sponsor of the Diversity, Equity, and Inclusion track of the Iowa Ideas Conference. As you participate today, be sure to connect with other Inclusive ICR champions, as we'd love to share information with you about our upcoming coalition meetings, projects, and how our work is impacting positive social change in our region. Be sure to check out our website at inclusivicr.org for upcoming events and our e-newsletter. Thank you and have a great conference.
My name is Sophia DeMartino. I will be moderating today's session. This issue is a personal one for me. I have 3 children. I have nearly died due to childbirth twice. Twice I have lost half the blood in my body and received transfusions. Twice I've had to seriously consider who would care for my children if I lost my life that very day. Twice I have come very close to adding to the maternal mortality statistics in this state. I want to begin today by introducing our amazing panelists. To our speakers, when you introduce yourself, please tell us your organization, your role, and a bit about how your work has been impacted by maternal health disparities. And I'm going to get started with Dr. Lynette Cooper.
Hi, I am Lynette Cooper. I am a clinical assistant professor of nursing at the University of Iowa College of Nursing. I'm also a nurse practitioner, family nurse practitioner, and I care primarily for I care for folks across the lifespan, but one of my practices that is relevant today is I'm the nurse practitioner for UAY, which is a community organization. I care for moms and families in their young parent program. I also work in developmental and behavioral pediatrics at the University Hospital. And just my entire career before I was a nurse practitioner, I was a staff nurse in neonatal intensive care and mom baby. So I'm very passionate about this subject. I'm also a mom. I've given birth in this state twice. And so these issues are very near and dear to me.
Thank you. Next, we have Lastasia Coleman.
Hi, everyone. My name is Lastasia Coleman. I am a clinical assistant professor in the College of Medicine here at the University of Iowa, and I am a certified nurse midwife. I have worked in this area for going on almost 13 years as I started my career as a mother-baby nurse and then worked in the hospital as a hospitalist with our high-risk inpatients who are pregnant, people who are ill during their pregnancy, and then joined our faculty practice in 2016. My areas of interest are more on health systems level, policy level, and addressing maternal mortality and maternal health disparities from policy perspective, working with Medicaid and our health department, things like that. I also am a mother. I have 2 daughters and also gave birth twice here in Iowa, and so have some lived experiences with that as well.
Thank you. And finally, we have Stephanie Moody.
Good morning, everyone. My name is Stephanie Moody, and I'm the Health Equity Coordinator with Healthy Birthday. And here at Healthy Birthday, we have a laser focus on stillbirth prevention, but we also focus on eliminating the racial disparities that exist and persist. Statistics show that Black women are 2 times more likely to lose their child to stillbirth and 3 to 4 times more likely to die while giving birth. My responsibility is to look at the inequities in birth outcomes in our state and the states that we partner with, and then develop strategies to address it. So we build partnerships with community organizations that serve within the marginalized communities so that we're not only educating the expectant parents, but also educating the providers, the doulas, midwives, home health and maternal health workers. So our goal is really to work together with those who are the boots on the ground, getting the information into the hands of those that are most impacted by stillbirth, and moving us from a place where race is no longer a predictor of stillbirth outcomes. I am a mother of 5. I gave birth to 4 right here in Iowa. So I have my lived experiences, as well as our family was impacted by stillbirth and by physicians who wouldn't listen. So I am excited to be here on today and excited to share.
Thank you so much to all of our panelists. I do want to mention before we get started that if you as audience members have questions, please enter those into the chat in Whova, and those will be forwarded on to me. All right, so our first question, please help us understand the historical context surrounding inequity in maternal mortality in this country. How have the events of the past impacted those you serve?
I'm happy to start with this one. I actually, in one of the courses I teach in the College of Nursing, it's basically an improving health systems course, and we have a huge section on health disparities. And I don't think you can actually discuss any kind of health disparities or disparate outcomes that we see in populations without looking at it from a historical context. And so this is something that's this conversation about how history affects what we see today is very it's in my wheelhouse. I do a lot of teaching about that. And so when we look at maternal health history as it pertains to Black women in particular, and Lastasia and I have actually talked about this on numerous occasions. Our history as Black women in this country, in one way or another, our bodies, our fertility, our childbearing has always been either controlled or, there have been attempts to control it. And so when we go back as far as, antebellum days, so slavery, our first introduction to the healthcare system or to, established in American medicine was as victims of barbaric healthcare practices, specifically pertaining to our reproductive health. And I don't even want to use the word health because the concern wasn't our health then, it was our reproduction and how many babies we could have in order to be a profit or in order to provide profit for the slavers. And so Black women essentially were bred for profit in the antebellum days. And that seems like, I don't know, it's not very easy to hear or discuss, but that is exactly what happened. And then when slavery ended and we were no longer profitable, our child birthing and those kinds of things was considered a nuisance. And so then we were subjected to eugenicist type practices, efforts to control our birth all the way up through, we can say today, but definitely through the 90s with, controversial birth control methods and practices that weren't proven and that were used, we were used for experimentation. And so there is a vast history that has, and these are not even the high points, like this isn't even the very tip of the iceberg, but even if, for example, the young ladies I care for in the community now, even if they know nothing about James Marion Sims, who was the father of gynecology, who experimented on women, on Black women in order to develop procedures, procedures that we use today, the speculum that we use today, we can thank James Marion Sims for, things that we consider useful, but they were pioneered and invented by, in very barbaric manners on Black women. And so even if my young ladies know nothing of James Marion Sims, they know nothing of Mississippi appendectomies or forced sterilization or Norplant in the 90s, they know it's very much alive in their psyche to be skeptical of healthcare, especially when it comes to their reproduction. And so I, even as a Black woman, as a representative of this healthcare system, I have the hardest time, helping my moms or empowering them to make birth control decisions because they don't trust it, because it's been used as a weapon against us. And I can talk about this for hours, but all of that barbaric history of the past is still very much alive in the collective psyche of Black people, but definitely Black women when it comes to reproduction, things that the general public is completely unaware of. It's in our bones, if that makes sense, even if we can't name James Marion Sims or, all these specific instances, that history has created a huge chasm and trust gap when it comes to healthcare and the Black community or Black women, and honestly, rightfully so. And so now we're just trying to empower the women we care for to, and arm them with good information so they can make the best decision for themselves when it comes to their reproductive health. So I'll stop there.
Any other thoughts on historical context?
There's no trust, like she said, when it comes to African Americans and the health community. Again, health was originally seen as a business and a profit. And so to bring it future forward, there was an article in the New York Times where they referenced a survey that was done with 222 white medical students. This was in 2016. And they published this, and it's called the Proceedings of the National Academy of Sciences. They showed that half of them endorsed at least one myth about physiological differences between Black people and white people, including that Black people's nerve endings are less sensitive than white people's. So when they asked them to imagine how much pain a Black person can take or what their experiences are in hypothetical situations, the medical students and residents insisted that Black people felt less pain. So this is in 2016. So there's no way when you're reading articles like this in today's world that Black women are going to trust healthcare providers, because these are the people who are going to be the doctors that'll serve them. So we've got to address the misinformation, the historical issues, the biases that are out there in order to make a change in all of this.
I just have two quick things to add. One thing that is very important for us to shift the frame on is that the health disparities we see are because of racism and not because of race. And so when we talk about things in risk factors is kind of a common thing we say in healthcare when thinking about different, demographic or health characteristics that put people at higher risk for certain outcomes. The risk factor isn't being Black. The risk factor is the systemic racism Black people experience in this country. So that's why we see worse outcomes. The other important thing, just to give a little bit more of a historical context, is that when we think about how healthcare and medicine have been established in this country, most medical schools were built in poor Black and brown communities. So this, even though they're trying to do better today, that's still where those institutions are, and that's where they're training new healthcare workers, is in Black and brown communities still today. And so that's just another important little tidbit to add.
Tell us about the current state of maternal health disparities in Iowa. How does this reflect on the assumed shared values that Iowans hold dear? For example, Iowa's a great place to raise kids.
It might be a good place to raise kids, but for Black women, it's not a great place to have kids. Stillbirth and maternal mortality, morbidity are intrinsically connected. And although we've seen a huge reduction in stillbirth rates over the last 10 years since the inception of our stillbirth prevention campaign, we've seen a 32% reduction in the stillbirth rates overall and 39% reduction in the stillbirth rates for African Americans. but yet we're still 2 times more likely to lose our child to stillbirth and 3 to 4 times more likely to die while giving birth. So we've got to address the inequities that exist in order to change these statistics. We've got to be real about the racism that is actually happening, the implicit bias that is controlling what people do and how they treat us, the misinformation about what we can and cannot stand, our nerve endings, whether our skin is thicker or not. All of those things have to be addressed, and we've got to start talking about it instead of being silenced about it. As long as we're silenced, it's going to persist.
I'm sorry, go ahead.
Nope, I was just going to say other thoughts
Okay.
about the current state.
Yeah, I think, I've been here since I started college. I went to, meaning here as in the Iowa City area. I lived in Des Moines for a little bit, but I came back. But I'm from Chicago, South Side. And so clearly my children are having a different experience growing up than I did. And so in some ways, okay, yes, it is a great place to raise children. However, I mean, I remember thinking, the whole mantra, is it heaven? No, it's Iowa. When I first moved here, I remember thinking, man, this is really a great place to be. But, and it is, but maternal mortality and infant mortality is only one of the areas where we see wide racial disparities. So I do think it's a great place to live and raise children, specifically if you're white. But we also have to grapple with, now my children, they may not experience some of the things that I grew up, but they're still at risk for being, for experiencing unequal treatment in education. I've seen articles from City High and elsewhere that talk about the different rates of punishment and suspension for Black children. I saw an article that talked about how Waterloo is the worst place to live in the country if you're Black, based on the wide disparities. And so when we talk about the best place to live, I used to live in Urbandale when I lived in Des Moines briefly, and that was on that list. But it is the best place to live if you are a part of a certain demographic. But what makes it worse is because for, Black people is that the disparities are so wide. White people in Iowa, by these measures are doing exceptionally well. And that's what they're looking at. But by contrast, the gaps are so great. And so I think sometimes it's just easy to ignore the smaller populations here and make sweeping judgments about the quality of a place based on how well the majority population is doing. And I think Iowa, Minnesota, like the Midwest in general is really great at glossing over those disparities in favor of how well the most well-off people are doing, if that makes sense.
I'll just add that one of the things that I would bring into the conversation for thinking about families and raising families is just the whole idea of reproductive justice. And so I was not doing great on reproductive justice in general. Part of reproductive justice is reproductive rights and health and things like that. So accessing reproductive services from birth control to just well person care to abortion services and things like that. And so Iowa has been a place that has not been very supportive in the last few years for accessing reproductive health care. And just as important as it is to be able to raise children in general, raising them in safe and sustainable communities is another important aspect of reproductive justice. So I don't know that a lot of the parents that I talk to feel like this Iowa in general is a safe community for them to raise their children, whether their kids are experiencing racism in schools or they don't feel safe with their kids walking by themselves, from the grocery store to the gas station, whatever, those types of things, because they're worried about things that might happen to them. This isn't really a safe and sustainable community in many aspects throughout different places in Iowa.
So unfortunately, surviving childbirth is really only the beginning. What factors play a role in the disparities that exist today? We've talked a little bit about some of the legacies of slavery. We've talked a little bit about racism. Are there other factors playing a role here?
So pregnancy is kind of, it kind of reveals things that might happen to you down the line with your health, right? So we see things like high blood pressure, diabetes developing during pregnancy, and that can be an indicator that as you age, you might develop those conditions, you know, as time goes by. But what we see is that people aren't, because of this mistrust in the healthcare system, people aren't entering healthcare and, you know, identifying these conditions that can lead to worse pregnancy outcomes because they don't trust the healthcare system. So they're not finding out they have diabetes or high blood pressure until they come in for prenatal care or something like that. So I think that that whole transition from being a child and getting care to being an adult and getting care and taking care of yourself isn't something that's well discussed either. How to navigate that when you move into adulthood, how even just how we talk about reproductive health and how people are sometimes hesitant to kind of talk about the full spectrum of sexual education in our youth. They don't know what to do when they become adults. And so that's why 50% of pregnancies in the United States are unplanned, is because people don't know how to navigate the system when they are adults.
Other thoughts on that one? All right.
Really, she hit the nail on the head. We have to remember that due to the lived experiences of our grandparents, our great-grandparents, and the things that they shared, a lot of us as African Americans were stuck believing that things are still the way that they used to be. And we have to understand that we can advocate for ourselves, learning that we have a voice and know what your rights are as a patient. So it's important that we educate our community as well, that they can stand and they can speak up so they can be given the proper care early on with those conditions that she spoke of, hypertension, diabetes, all of those things, especially when it comes to maternal health. Getting that care early on is going to help you to navigate those issues that may pop up later on.
What misconceptions exist related to maternal health disparities, and how do those affect progress towards saving lives?
I know we talk a lot about like medical related causes to maternal death, whether that be things like you mentioned, Sophia, with hemorrhage, things like high blood pressure and hypertensive disorders leading to maternal death. But I think it's also really important to remember that when we're talking about maternal death, we're also talking about causes of death that are not related to health. So things like homicide and domestic violence. In states like Texas and Louisiana, their numbers show that that's actually the leading cause of death in the maternal period. So that's an important thing to consider. Other things like mental health are not well spoken about and stigmatized, but in Iowa, mental health is a huge contributor to maternal death through the form of suicide or substance use disorder. And so those are important things that we don't always think about, but those are those things that come up in that postpartum period where we're seeing a lot of deaths between the time a person gives birth to a year after they give birth, where we can see those things like heart disease cause deaths, things like suicide due to depression cause deaths.
I think some other misconceptions, I think we have a lot, honestly, especially when it comes to racial disparities in particular. There's a term that I hear used called mother blame, or the mother blame narrative, especially when it comes to marginalized communities, especially, I hope it's not controversial to say that anti-Blackness in the country is a very real thing. And so I think when we have, a community like, or, a population like Black women experiencing, disproportionate amount of maternal deaths, I think it's very easy as healthcare providers to slip into the mother blame narrative. If this community would just, if they, didn't have this much of this and this much of that, and if they would go to the doctor, and if they, these kinds of things, but the truth is almost, I think the number is about like 60% of maternal deaths are preventable, but a lot of that comes with what we as the healthcare community and as a society could be doing to ensure the health and safety of moms and babies. But I think in healthcare, sometimes we put the blame back on communities and on individuals when they suffer disparate outcomes, because especially because of things like, because of bias, and in particular, anti-Blackness. And this is why I also think that historical context and understanding that racism is baked into all of our systems, and without kind of rebuilding, even if we're going to see these wide disparities. And so I think, that's the biggest one, the biggest misconception, the biggest myth that I think keeps us from moving forward, is that it's because of the communities themselves or because of individuals that we're seeing these disparate outcomes, when this is a systemic, societal, historical issue. And then I also think that when it comes to things that specifically affect certain populations, including Black people, there's an empathy gap. It's almost as if this country is fine with accepting racial disparities because, again, of, anti-Blackness and a lack of understanding of how the systems have created these problems. So I think that's how I see that particular question.
So I do want to say this is a safe zone in which to be controversial. We are here to tell the truth today, and that is not always comfortable. So that's what we're doing. Some very high profile celebrities, for example, Serena Williams and Beyonce, have been candid about the childbirth experiences that could have ended their lives. How does the publicity around those kind of stories impact the work?
It actually opens up the door for us to have these real conversations. It shines a light so that we can talk about the fact that Serena Williams was not believed by her own doctor. If it wasn't for her spouse speaking up, she very well could have lost her life. And she knows her body better than anyone. She's an athlete. She's a professional athlete. Her job has to know what is going on in her body. So this opens up that door, it shines that light, and we get to have these conversations. And we've got a recent situation where we can talk about, yes, this still exists. This is not a once in a lifetime situation. This is something that is happening far and wide in this country. And we've got to be honest and real and open to having this type of dialogue and hearing the truth of these lived experiences, and then setting up something to do something about it. We've got to move to solution. We can talk about it, but until we do something about it, it's going to remain the same.
Other thoughts?
Yeah, I also think that bringing more high profile Black women into the conversation also illustrates that it's race. It's beyond socioeconomic status. It's beyond, prior health status, because who's healthier than, her body is a machine. It's her livelihood, who's more fit than Serena Williams. It's beyond educational level. It's beyond all of these things that we like to point the finger at when it comes to health disparities, when we know that regardless of a Black woman's educational attainment, regardless, even those of us within the health, we've had high profile deaths of Black women doctors and Black women epidemiologists, and, as well. And so I think those horrible tragedies open up the conversation even more, that this is not just an issue that, if we just had universal health care, which is important, or if, they were healthier, or if, they didn't do this and didn't do that, then they wouldn't see these outcomes. We know that regardless of our station in life, as Black American women, we are at higher risk when it comes to maternal mortality because of racism. And so that opens up that conversation when you have people like a Beyonce, like a Serena, like the physicians and epidemiologists and people that have also had these horrible outcomes.
I do again want to remind the audience, if you have questions, go ahead and type those into the chat box in Whova so they can be forwarded to us. How have the actions or inactions of policymakers and government leaders affected maternal health disparities? What could be done by lawmakers to make a difference?
So I do think that one of the things, as I mentioned earlier and Lynette just kind of alluded to, is insurance coverage. And so we know that a good proportion of deaths, depending on state by state, vary, but about 30 to 40% of maternal deaths happen in the postpartum period. And for many of these birthing people who are covered by Medicaid, they lose their coverage after 60 days after they give birth. If you think about time passing, 60 days from when you give birth, like you barely have had your postpartum exam, you're just probably figuring out breastfeeding, you're probably trying to figure out going back to work, and you're not, again, refocused on your own health at that point. So if something's going on, you may have not followed up on it yet, like things that have happened during the pregnancy, you might not have had a chance to follow up on. And so having postpartum insurance coverage extend into 12 months after birth is really one of the most important policy changes that we can see, where people will continue to have coverage so they can seek care and follow up for things like mental health, diabetes, high blood pressure, and make sure those conditions are being managed in the postpartum period. Other things, in general, there's just been an underinvestment in reproductive health in our country. And so there's just a lack of things like funding for research. Like there's no center for reproductive health, nationally. And so there's just a huge opportunity to be doing more work in the area of reproductive health. It's just other things have taken the spotlight historically. And so we just don't have funding for a lot of the same things other specialties do.
Other thoughts on policy?
Go ahead, Dr. Cooper, and I'll go right after you.
Okay, I think healthcare is number one. Improving access is number one. But in addition to that, when you look at the health of a community or population, depending on what statistic or studies you use, healthcare and access to healthcare is only about accounts for only about 10 to 20% of the health of a population. And so in addition to universal healthcare, we need to be closing these other disparities across the board. So we need housing, we need education, we need environmental justice. We need food, you know what I mean? Like we need universal, when our children are born, before we have other children, we need, childcare. There's so much more when it comes to policy that has been neglected, that these upstream issues before they even come to us as for healthcare that we need to address. So I think sometimes, at least politicians, when they talk about universal health care as the answer, but I think it's an answer or part of the answer. Because if we don't address these upstream factors, then we will see maybe some improvement in outcomes, especially for non-Black people, but also for Black people. But we're not going to see those those gaps close in the way that we'd hope to, if we don't address the other upstream factors that contribute. If we don't pay people a living wage, and so if we're not really addressing all of those things that happen before they even get into the healthcare setting, then we won't see the outcomes and the improvements that we hope to see, even if they had all the access in the world, And we know that when we look at Black women and maternal death in particular, and that with access, with education, with we don't necessarily see those gaps close, because racism is still built into all of the other systems, if that makes sense.
And you covered it, so thank you.
I was just going to add one more thing, Sophia, just off of what Dr. Cooper said, in that things are very siloed right now, and that's just how we approach it. And so it's really hard to think about how different, even between healthcare and public health, can work together to improve outcomes, because healthcare is very much over here and public health is over here, and they have different goals and perspectives that they bring. And then we're not even really trained on how housing impacts health, or how access to grocery stores, like the other social determinants of health, impact health. And so I think that's the direction things are moving in, but it's still, when it actually comes to doing things and making change for the people who need it the most, we have to think about more of a synergistic approach than keeping our work in silos.
So I'm going to go to an audience question. This question says, we can all agree that as Black women, we are the minority group that everyone forgets, but how can we get more Black doctors, RNs, CNAs to stay in Iowa?
The workforce issue is definitely one that is overlooked. Again, the system of, educating and training healthcare providers is working the way it's intended, with disparities in underrepresented minorities entering these fields. So there has to be deliberate work in improving the diversity of our workforce. Pretty much everything that you read, that all these reports and recommendations state that we need to work on diversification of the workforce. There's also been studies done recently, both for maternal and infant health, that show that if there's racial congruence with your provider, you have better outcomes. I believe the study that was done for infant showed that if there was racial congruence there, that they were 3 times less likely to experience infant mortality if their provider was also Black. And so it's very significant impact on the actual patient-provider relationship. Things that we can do, I think when we approach education, we approach it just from a programming perspective, as we're just here to educate people. But I think if we're hoping to diversify our workforce, we have to think about approaching the whole person and not just them as a learner. And so oftentimes, for example, in my field of midwifery, people are coming into midwifery later in their lives. They usually might have families or be established in a community or something like that. And we have to take that into consideration if this is the group of people we're trying to target to educate. And so we need to think about things like, how can we help them access funding for housing? How can we help them with childcare? And not putting them into a huge amount of debt just to become whatever role they're hoping to enter into. Because that's a huge barrier. We know that Black women have the highest amount of student loan debt in the United States. And so just being mindful of those things and not just approaching education from I'm just here to teach you and that's it. We need to think about it from a holistic perspective.
I actually didn't know that we had the highest student loan debt, but I felt that.
I was gonna say, yep, that checks out. When I look at my own, that checks out. But it's true because many of us, especially when it comes to advanced degrees, we're not coming with a foundation of income and family support, and other things when we're, a lot of us, especially with advanced degrees, we're already, and I'm not saying this isn't true for other populations, but we carry a lot of responsibility, not only to our families, like our immediate families, but sometimes to our extended families, if you are already, a professional. So like, when I was a nurse, seeking master's and doctoral education, I'll just say that my money wasn't just my own, and so, and I did not have family support, or meaning I had lots of emotional support, but not necessarily financial support in that way. And so, there were times when student loans helped to make ends meet, while we were in school. And so, yes, that absolutely checks out. But to the original question, I'm faculty. And so as we look at, needing more Black doctors and Black nurses and nurses of color, doctors of, people in this state to care for this population, academia, it starts with academia. It starts with, how we are recruiting, who we're recruiting. And I think sometimes we've just settled that nursing, for example, is primarily white and female. And we haven't done the extra work. And I'm not talking about my college in particular, I'm talking about more of the profession. We haven't necessarily done the work that it takes to diversify our educational programs so that we can produce a more diverse workforce. And honestly, in Iowa, there's this misconception that we don't have people of color here. I mean, we're here, and so there's this misconception that it's okay to have a 95% white student body. Because there's this idea that that represents the state, and maybe in numbers, maybe, but that doesn't necessarily represent our hospital populations and the people seeking care in Iowa, if that makes sense. And so I think that even before they get out into the workforce, in the educational programs, we have to be intentional and we have to walk the talk. You hear a lot about DEI and valuing diversity and all this, but the proof is in the pudding. Who are you educating in your programs? Do your standards or, admissions requirements, for example, do they prioritize the privileged? So if your program requires a 28 ACT, who are you automatically disqualifying? Because I know, like I said, I'm from the South Side of Chicago. I took the ACT in my senior year. I did not have a mother that went to college that knew the ins and outs of how to prepare me for that. I didn't have a mom that knew that you could pay for programs to improve ACT scores, or I didn't go to a school that had all of these advanced placement courses and, all those things. Now, did that make me any less of a capable student and eventually a capable nurse? No, but we sometimes put value on things that don't necessarily translate to a more diverse workforce. Standardized testing is just one of those options. If we're looking at applications and we prioritize those with lots of advanced placement courses in high school. Well, I went to a city school that didn't have that. But my counterpart that went to a school in the north suburbs, they absolutely, because it was from a high resource community. So I hope I'm making the point that I'm intending to make. In our educational programs, we have to change what we value, because sometimes our values prioritize privilege over what the actual workforce needs, what our patients need, at least in healthcare, if that makes sense.
And to that point, we do have an audience follow-up. What advice do you have for those who serve on a nursing college advisory board in order to diversify the student population?
Well, we need to look at population trends, and we need to, a new Future of Nursing report just came out, new Essentials just came out. And in those, they are prioritizing diversity because they're recognizing that a diverse patient population needs a diverse workforce. And so what we need to do, there's a process called holistic admission, where we're looking beyond an ACT score or, a 4.5 GPA, which that's a thing, to what more does the person have to offer the workforce. And so I think moving toward holistic admission is important, and really thinking about how admission requirements meet up with your actual goals. Like, what's your goal? Is your goal to have your entire class that you admit, wealthy, white, high achieving in those standards? If that's your goal, then keep, standards that get you there. But if your goal is to diversify, then we need to move away from that and move into more holistic admission, because that creates, we need more well-rounded candidates, if that makes sense.
I would also add that the inclusion commitment is often missing in these equations as well, where even if places are trying to do this holistic admission approach, when they get students there who aren't in their regular, 95% white, high achieving, have had all this educational prep, they don't know how to work with those students. They haven't put the structures in place to help those students also be successful. And so it's great to have a lovely admission rate that shows that you're admitting a diverse population, but what about who actually graduates from your program? And so you have to have those structures in place that are going to support those students. Things like, hey, can we help you access childcare services? Can we help you find tutors? Can we help you make sure your housing is going to be stable? You can get groceries, like that type of stuff. We have to just switch the game up a little bit and think about things from that perspective, because those aren't the things that colleges are used to helping their students overcome. But if we're hoping to diversify the workforce, those are things we're going to have to address.
Absolutely. And even if we graduate a more diverse workforce, what was their experience in our college? Like, that's one of the things that I if, okay, we had more, male students, we had more Black students in nursing. Male students is a big deal, but we had more Black students, we had more, immigrant students, we had more undocumented, those kinds of things. But what was their experience with us? Were they microaggressed at every turn because the workforce wasn't prepared, for that? And so, yes, I just want to wholeheartedly agree that diversity is just one part of the equation, and it doesn't work if you don't have inclusion, equity, and if students don't really feel like they belong. And that's one thing that even in my work or in my college, I'm wanting we've been having conversations about diversifying and those kinds of things, but what is the experience that students are having when they come to us? Do they actually feel like they belong? We're not, are we tokenizing our, students of color? Are we doing this to make ourselves look good and say, hey, look at these numbers, without actually meeting the needs of the individual? So yeah, no, I just wanted to definitely agree with what Lastasia added to that.
Can you tell us about the work that's being done here in Iowa to eliminate the maternal health disparities that exist?
So there's a number of things being done. I'm part of a maternal health innovations grant from the Health Services Research Administration from the federal government. And we know one of the most important things to address some of these medical causes of maternal death are to have a really solid maternal mortality review board where you're looking at it from a multidisciplinary standpoint and making recommendations about how to address the things that are causing maternal mortality in your state, and also having a maternal quality care collaborative. So a care collaborative is essentially stakeholders from all hospitals that serve birthing populations, so they have a labor and delivery unit, working together within the group of the collaborative and also within their own hospitals and health systems to improve the way that care is being delivered. And so the model that most states follow is the model that California set forth in the early 2000s, where they were one of the first states to have a maternal quality care collaborative. And they not only decreased the maternal mortality rate, they were the only state during this time where we look at maternal mortality rate that actually went down. Everybody else has gone up. But they also narrowed the disparity gaps in some of these conditions that we see, things like hemorrhage or hypertensive diseases and things like that. And the reason that these care collaboratives work is because they follow evidence-based bundles of care delivery. So things like measuring blood loss instead of just guessing what it is. Amazingly, it's like standard to just guess what blood loss is and deliveries, estimated blood loss. So actually quantifying it by measuring it. And then following a protocol to tell you what you do at each stage when a blood loss reaches a certain volume. So doing things in the standardized approach helps to eliminate bias in the way that care is delivered, because you do it the same way every time, no matter who the patient is. And so that's one of the ways that California has decreased their racial disparities in hemorrhage outcomes, is because once you implement these bundles of how you manage these conditions, the disparities are diminished significantly because you just do it the same way every time. So that's something that we're doing here in Iowa. Our first bundle that we're working on right now is to safely decrease the primary C-section. And so we know C-sections come with greater risk for things like hemorrhage, infection, and then requirement of further C-sections, additional C-sections with subsequent pregnancies if you aren't in a center or aren't a great candidate to attempt vaginal birth after C-section. And so, teaching different hospitals how to utilize different techniques. A lot of them are very much like midwifery approaches to birth, with like limiting intervention, how to manage fetal monitoring, tracings, and not just jump to doing a C-section at the first sign that things might need intervention. That's not the go-to intervention unless that's what's actually necessary. A lot of hospitals have already in Iowa have done the hemorrhage bundle, and so these interventions are really important in addressing these medical causes of maternal death. Other things in the state, I know the state overall is looking at Medicaid expansion. We already actually do a really good job in our state with coverage. We have one of the most generous federal poverty line cutoffs of all states in the US, where we're at about 375% of the federal poverty line. Most states are at about 138%. And so at least in our state, people are able to access Medicaid at higher rates because of that cutoff. So just extending that to the 12 months is kind of the next step that's being evaluated currently.
One of the things that we're doing is we're focusing on improving birth outcomes. So our goal is to help to not only save babies, but moms, because we know that fetal death and maternal mortality are intrinsically connected. Maternal mortality and morbidity, they're intrinsically connected. And so what we're doing is we're working to make kid counting a common practice for all expectant parents in the third trimester, getting those doctors to integrate this into their practices. But another thing that we're doing is called the OBED project. So we've partnered with the hospitals in Polk County. So this isn't a statewide thing yet, but we're piloting in Polk County. And so we're working with the different hospitals, Broadlands, Unity Point, and Mercy One, and also partnering with United Way on this project. And so what we're doing is we're working together to examine and improve the statistics that's related to the patient visits to the OBED. and any barriers that exist and persist with them accessing a primary care physician, an OB, or even a midwife. So the data is showing that there's definitely significant barriers that persist to accessing a primary care physician or an obstetrician. And Black women are disproportionately showing up in the local ERs seeking care sometimes 30 to 40 times more than their white peers. So we're investigating why. And what we're doing is we're working together to create a patient communication plan and implement hospital protocols that connects the patients to that primary care physician, an obstetrician, and even a midwife, doulas as well, so that women without these important providers, they can receive that preventative care right away in the early stages, of fetal development. And we want them to build that relationship early on with their regular provider and spend less time in the OB/ED. So that's one of the projects that we're working on here, and we're hoping to be able, with the successful statistics and data, we're hoping to take it statewide.
I'll add that I see patients. I have patients I practice, but I do primarily work on the education side, so students. And so I'm a part of, a couple different research teams that are focused on the experiences that Black women are having, with, and not just childbirth, but with also their just seeking reproductive health. And the goal there is to gather these experiences, to do, qualitative research and gather these experiences that Black women in this state are having, so we can take it back to providers in this state, so they can see these are the outcomes and these are the experiences, these are the interactions that your patients here that are Black women are having with you. And, not in an accusatory or anything like that, but, as an educational tool to say, okay, this is what they're experiencing. What can we as the healthcare community do to improve not just their, primarily their outcomes, or we definitely want to improve outcomes, but we want to improve the experience. Because honestly, if you, when I go to the doctor and they ask me, do your kids have the same baby daddy? I'm not going back to them. Or when my young moms in the community go and they have their white family support worker from UAY go with them, and then the doctor immediately stops talking to them about their health and their child and starts talking to the white social worker, then they're probably not going to come back. And so we're trying to improve the experiences we want to hear the experiences, make sure that the medical community is hearing the experiences with the hope of eventually that translating into improved outcomes. But also in the classroom, it's unfortunate how little healthcare students how much education they get in terms of social determinants of health, and specifically race as a social determinant, which is more racism. And so we're trying to be more intentional about incorporating that, threading, those concepts throughout their education from the time they come into our doors until the time that they leave. And so that they understand that diversity and inclusion, it's not a buzzword in healthcare. This is foundational to our role as healthcare providers. Social justice needs to be a part of what we do, and improving outcomes for our most vulnerable needs to be second nature. So, there's research going on. We're working on the education, at least in this state. And so that's some of what we're doing.
So we've got sorry, go ahead.
Sophia, I was just going to add two more things. I'm going to put in a plug for the Black Women's Maternal Health Collective that Sophia, Lynette, and I are all on, but we're working, with the pandemic, it was really hard to have this community engagement. So we're getting back together and trying to figure out how we can still do community engagement. We were hoping this would be over by now, but we're still in it. And so we want to make sure we're still getting into the community and giving people support that they need. Another project that I'm working on specifically for our Black community is the Title V program from the state has a Black doula project where they're training doulas, both kind of like native-born Iowans who are Black and also our migrant and refugee populations to have doulas in those specific communities. And so they've hired someone to come in, and I'm just one of the consultants on the project. And so am aware of what's going on there, but I think that's going to be really helpful. As we know, doula support has been shown to improve birth outcomes. And so when we have culturally congruent doulas, that's even better.
Thank you. That is exactly what I was going to bring up in our last 60 seconds there was the Black Maternal Health Collective. So thank you for plugging that for me. I want to say thank you so much to all of you for lending your expertise and your time this morning. I am so grateful to get the opportunity to talk with you today. Thank you to everyone who has joined our session. If you would like more information on the topic, I think we can put some links in the event page later. So thank you so much for joining us. Have a wonderful rest of your day.
Thank you.
Thank you.
Bye, ladies.